Well, thank you very much for coming today. I'm Stephen Thorpe, Chairman and Founder of CME Medical. And I'm delighted to be here today because they don't let me out to play very much nowadays, so thank you for the opportunity. For those of you who don't know, CME is a specialist infusion company that basically focuses on niche clinical specialty areas and designing infusion systems for those. And fundamentally, we do that by looking at safety issues and utility issues within areas and working with physicians like yourself to solve problems. And that's where our relationship with Andrew started many years ago, because Andrew is obviously very well known in the field of palliative care. Wrote the textbook, The Syringe Drivers, on syringe drivers and medications given in syringe drivers in palliative care, which very much is a global bestseller in the palliative care. I think Andrew said he made it to number one on Amazon one night.
He did, yeah.
Yeah, but just after he bought 25 copies for himself, so... Sorry, I said no, sorry. So basically, we work with Andrew to discover all of the issues in palliative care and design those out of from the older equipment, which in its day was revolutionary, the MS Driver, and created the T34, which is a modern replacement for that. And so we wanted really Andrew to come and talk today about an update on what's happened in the area, and also some work that he's doing that's pushing forward in palliative care medication, pain and safety. So thank you for coming, and I'll pass you over to Andrew. There is one thing I have to say, though, before I do. Sorry, I almost forgot the housekeeping. Apparently the session is being videoed, so if you want to ask questions afterwards, they won't be videoing you during the questions, and if you've got any issue with being on the recording, I think it's a Pain Society's recording, then you just have to let us know afterwards, and they'll strike you from history. So, but thank you very much anyway, and Andrew, pass over to you.
All right, just wait while I put this on. Okay, thank you for the introduction, Stephen. Thanks for turning up. At least we've got some here in the twilight zone. I'm going to talk today about syringe drivers, subcutaneous infusions, and when we look at, are we sure that the patient's getting what we prescribe? Well, obviously, we're looking at chemical-drug interactions here, so I'm going to talk a little bit about that towards the end. So what you're going to hear from me over the next sort of half an hour or so is obviously all to do with me, nothing to do with Blackpool, which is where I work. We'll start off right at the beginning in the 1970s. Great inventions. We had the black and white TV. Michael Jackson was Michael Jackson. First home computer. We had the Boeing 747 that came out in the 70s, and we also had the first supersonic B-1 bomber. And also in the 1970s, we had this device, the syringe driver, the MS-26. Doesn't look like much. Technologically, it doesn't look like very much either, but it was certainly revolutionary as far as palliative care was concerned. Now, if we look at some other revolutionary inventions over the years, we've got the Model T Ford. And this came out in 1908 and went on to the 1920s. And it revolutionised the motor industry. And it's interesting to see that the Top Gear car last year was also a Ford car. It was the Ford Fiesta. Well, anyway, getting back to the Smith Greysby MS-26, it has been the mainstay of palliative care for the last 30 years. And the inventor, Basil Martin Wright, thought it was going to become an essential component of British palliative care, and indeed it did. But its use in palliative care was by chance. Martin Wright, his GP, was also his neighbour. He was called Dr. Patrick Russell. And during the usual friendly discussions that they had over the fence, the idea of a continuous subcutaneous infusion came to light. Russell described the first use of a syringe driver and a continuous subcutaneous infusion that was used in a hospice in 1979. Until this day, the use of continuous subcutaneous infusions is the mainstay of symptom management in the care of the dying patient. But the popularity of that little device was undoubtedly due to several factors. It was small, it increased the patient's mobility, it was relatively simple to use once the nurses had received training. It was manufactured in the UK by a company called Pi Dynamics, and they were originally involved in armaments. And it was later then taken over by Greysby, which invented depth charges. So the idea of a syringe driver from a depth charge, I don't know where that came from. But this is what they look like. There's two of them, the MS-26 and the MS-16. The blue one is the one that delivers in an hourly rate, and the green one, 24, the MS24, that delivers over 24 hours. They've both been very useful servants for palliative care, but the days have now passed. Basically, they don't comply with that particular British standard, international standard there, 6061224. I'm not going to go into what that is. But in 2010, the NPSA issued a rapid response, basically telling us that we have to get rid of these Graysby syringe drivers. The NPSA recommended pumps that have rate settings in millilitres per hour, not millimetres, a length, which is what the Graysbys were set up at. They also needed to have a mechanism to stop the infusion if the syringe was displaced or it wasn't securely fitted. The NPSA also suggested that new replacement devices should have alarms that activate if the syringe is removed before the infusion is stopped. The older devices, the MS26 and the 16, didn't have that security. They also recommended that there should be a lockbox and or a cover which was controlled by a password, or rather a lockout was controlled by a password. And more importantly, they thought it would be a very good idea if there was an internal log memory to record all events that happened over the duration of the infusion. This would be useful, for example, in trying to identify if anybody was trying to tamper with the infusion. Now, the NPSA issued this in December 2010, and it was for immediate action by trusts, NHS organisations, and also in those in the independent sector. What they also stipulated was they wished to make sure that the introduction of the new syringe drivers took place by December 2015. Before 2010, New Zealand and Australia had already gone through this process, and they already had the new replacement syringe drivers in place. So then we come on to CME. Well, not to be outdone, and continue along with the military theme, CME named its device after a tank, the T-34. And this is what it looks like. But when you go onto the internet, and I wanted to find a picture, this has come from CME, but I tried to find one that was actually on the internet, so I googled T-34. I came up with a few things, but this also popped up as well. It's quite ironic that we use it in palliative care, isn't it? Right, 2010 was the NPSA alert saying we had to get rid of everything by 2015. This is the current map in the UK that's looking at those that have swapped over to the T-34. Green is obviously good, red is very bad. So if you live in a red area, you need to go back and make sure that you're changing because you've got just over 18 months left. I should also point out that hot off the press, the Graysby MS26 has been discontinued. Is that correct? Yeah, so it's no longer available anyway. Okay, so now we'll go off on a slight tangent to look at needle stick injuries. Now, injuries that are caused by needles are probably one of the most serious risks to healthcare workers. In the UK, it's estimated that about 40,000 incidents are reported each year, but there's probably double that amount because many go unreported. Many aren't considered serious and they're just ignored. So, based on your maths, that's about 274 needle stick injuries per day, or 11 per hour. Like I said, there's probably a lot of underreporting in the NHS because many of these won't be considered important, but it is certainly a major concern for us. If we look at the breakdown, when do they occur, the needle stick injuries? I don't know how well you can see this, but the biggest two proportions here, 40% each. One is during the device use itself. The other one is after the device use, but before it's been disposed of. And when we look at the professional breakdown, well, it's not important, it's not surprising, is it, that nurses at 44% are most at risk of a needle stick injury. But they do pose a significant problem to the NHS, not just to the individual healthcare worker, but also the economics of it. It's very expensive. A report in 2011 suggested that each trust per year, it costs them about £500,000 for needle stick injuries. And then we move on to legislation. In 2010, there was an EU directive that suggested that needle stick injuries are one of the most serious health safety threats for European workplaces. Now, the purpose of the European directive was to achieve a safe working environment, prevent... We seem to have missed the top of the slide, but never mind. The purpose of the directive is to achieve a safe working environment, prevent injuries with all medical shops, that including your needle sticks, to protect workers, to set up an integrated approach that establishes policies in terms of risk assessment, risk prevention, set up training for nursing staff, provide information and awareness, and raising monitoring. The EU law came into force last year in May, much to his disgust. We've now got a law in the UK, Health and Safety Sharp Instruments in Healthcare Regulations 2013. These build upon the existing UK law, basically making sure that healthcare workers are protected from needle stick injuries. So the specific requirements for NHS employers, promote the safe use and disposal of needle sticks, make sure there's detailed training for the staff. If an injury does occur, make sure it's responded to effectively, and make sure that all processes are reviewed regularly. So the devices that are of particular concern, we have the wing giving set, and we have the IV cannula. So what's available? Well, we have this device. It's a safety catheter system that's been approved for subcut and IV use. It's an integrated system, limited risk of needle stick injuries. There's less exposure for healthcare workers to blood, bodily fluids and medications. In a nutshell, there's less risk to the staff, so it's a safer device, and it's certainly something that we've swapped over to in our trust as a result of the regulations. So that's the mechanics of subcut infusions. Now we're going to talk about the actual drug compatibilities. For some of you, I'm afraid, we're all going to have to go back to school. Particularly, we're going to have to look at the old periodic table and look at chemistry. When we talk about drug compatibility, what do we mean? Well, if we talk about incompatibility, this is a theoretical reversal or a physicochemical change that results in precipitation or insolubility. But more importantly, or most importantly, it's not always visible. You might find little tiny crystals that you can't see with the naked eye. An example here of an incompatibility is midazolam and dexamethasone. If you mix the two together, initially you'll see a nice white turbidity. If you give it a shake, it'll go back into a clear solution, but you won't see are the tiny little crystals that are still in solution. Then we come to instability. Well, this is an irreversible change, and it results in loss of potency of the drug in question. And an example here for you is glycopyrronium and dexamethasone. If you mix those two chemicals together, you have an esterification reaction. If you can remember what that is from the dim and distant past, it's essentially acid and salt mixing the two together. Sorry, acid and base mixing them together, and you get salt plus water. So you get an ester that's derived from that reaction, and you've lost your glycopyrronium out of solution. Now, it's not that hard, actually. Most of the chemical reactions that we see in the syringe driver, when you mix them together, if you have a basic understanding of acid-base chemistry, you can predict whether drugs are going to be compatible or not. Now, the thing that determines whether you're going to get a reaction in the syringe is governed by what we call functional groups, and there's about 20 at least. So if we take diamorphine as an example, here we have ester groups. Then we have an ether group. We have tertiary amines. We have alkenes. And all of those can be considered important when it comes to looking at chemical reactions when you combine drugs together in a syringe. Now, the most common chemical reactions that are implicated in drug instability or drug degradation involve hydrolysis, which isn't surprising as most of the solutions are in water, or oxidation. Now, parenteral drug degradation is also affected by other factors, such as light, so it's sometimes useful to keep syringe drivers out of light, direct sunlight, pH and temperature. I don't know how many of you have actually seen levomepromazine turn purple in sunlight. We've had patients who've walked outside with the syringe drivers attached to them. They've gone into the sunlight and the giving set turns purple, and that's levomepromazine as degraded in the sunlight. Another example here that's based on pH is midazolam, and what we find here is this is the soluble midazolam in solution. If you increase the pH, what you'll find is it precipitates, and that's what causes the problem. It does leave you feeling like this though sometimes. So, what about drug compatibility? Well, when we mix drugs together, we're not quite sure what's happening, are we? There's going to be unknown reactions. In 2007, the NPSA issued an alert, and the MHRA in 2008 issued recommendations about drug compatibility in syringe drivers. We need to avoid incompatibilities, prevent medication error. To begin with, though, when we try to look at whether two drugs are going to be compatible or even more than that in a syringe, we need to see what's available in the literature, and there isn't very much there. And there's only a few reference sources that we can refer to as well. It's like I say, we don't know what's happening. For the majority of drug combinations that we use, we don't know what's happening chemically. Are they stable? Are they compatible? Has something precipitated? Has the drug potency been lost? Or even worse, have we performed some toxic compound? We do know that we get site reactions occasionally with subcutaneous infusions. Is this due to a toxic compound? We don't know. Is this what we're looking at? So, when we've decided, okay, we need to do some chemical tests here, well, how many drug combinations are there? How many possible combinations are there? Well, assuming there are 5 opioids, and the majority of our syringe drivers contain an opioid of some description, and assuming there are 15 other drugs, supportive drugs, that could also go in there as well, and each combination typically consists of at least 2 or 3 drugs, how many combinations are there? Well, you could use that equation, but that looks a bit complicated to me. Or you could use Pascal's triangle, which is very helpful. And if we scroll down here, the line that we're interested in is that one. This relates to the 15 other drugs that can be combined with an opioid. And it's a lot, and I'll come back to this in a bit. So we decided that we would go ahead and try and do some sort of chemical analysis. And this is where this trial was born, the ChemDale trial, the chemical compatibility of drugs administered by continuous subcutaneous infusion for end-of-life care. So what we did initially for a pilot study, we did a Delphi study asking people what they thought were the most common drug combinations that they used. And we also did a database analysis. And from this we identified 4 opioids that were being used, and this was the order of preference. So morphine seems to be the most commonly used first-line opioid in the UK at the moment, followed by alfentanil and oxycodone, and surprisingly diamorphine has fallen out of favour. It's certainly still used in palliative care, particularly for those patients with the higher dose requirements, but it's certainly not as popular as a first-line choice anymore. And it's not surprising, because those of you who can remember in 2004, just before Christmas, we got that lovely alert warning us that there was going to be a nice diamorphine shortage. And I think it was Christmas Eve, wasn't it? And so it sent us all into a big panic. What we're supposed to do, what guidelines can we issue? So most centres swapped to morphine at that point anyway, but some centres have swapped back to diamorphine. When we looked at common mixtures of the other drugs, this was what we found. Cyclizine and haloperidol, cyclizine and midazolam, levomepromazine, metoclopramide, haloperidol and midazolam, hyoscine and levomepromazine, metoclopramide, midazolam, cyclizine, haloperidol and midazolam. And the most common one out of that was metoclopramide and midazolam. And so this was the combination that seemed to be used most frequently in our local practice. And when we sent these combinations away to the chemists, they sent us pictures back like this, chromatograms. They set up the syringe drivers, they tested them over 24 hours, and they ran them through an HPLC machine. And this is what we found. These are the spikes. So, for example, we're looking at oxycodone, midazolam, and haloperidol here. This is what we see initially, nice big peaks, and after 24 hours, we want to see exactly the same. If we started to see different peaks coming through, that would suggest that there's some chemical reactions taking place. Now that looks quite complicated to me. Unfortunately, I was helped out with our 3 wise monkeys and they explained everything to me. We did identify 2 additional mixtures which contain glycopyrronium. Now glycopyrronium is dosed in micrograms, whereas all the other drugs are dosed in milligrams. So when you put this through an HPLC machine, you're stuck with you come across a very, very tiny peak there. And so it's very difficult for the chemists to say whether or not you've lost some of the compound. So they've gone away and they're devising a different test to be able to decide whether or not these combinations of glycopyrronium are stable or not. So we combined each of those 5 opioids that we saw at the start with each of those 8 mixtures, and we got 40 combinations to stick through the HPLC machine. All of them, I can say, were chemically stable, which is good to know, with one exception, which is currently going through further analysis to find out why, whether it was experimental design error or whether it was the technician's mistake. But alfentanil, hyoscine butyl bromide and levomepromazine showed more than 10% degradation of levomepromazine over the 24 hours. So we then progressed on to a big 3-year project. Now, when I asked you before how many combinations are there, well, there's roughly about 50,000 possible combinations, and quite clearly there's absolutely no way we'd be able to test all 50,000 combinations. This is based on the assumption that there's about 29 drugs that can be administered by subcutaneous infusion. Now, like we touched on before, the most common combinations contain an opioid because the majority of our palliative care patients will suffer pain. In clinical practice, though, we're probably looking at about 3,000 mixtures that we will actually use. But 3,000 is still an awful lot to try and put through a chemical test. So we needed to come up with a method of identifying those common combinations that are used at the end of life, and then we would test those accordingly. We did a literature search, and we found that there was only 70 combinations that have actually gone through a chemical analysis. So this project aimed to identify commonly used drugs at the end of life for symptom management. We invited pharmacists to complete a national database for us, and we locked the database once we got to 2,000 entries. We also did a parallel Delphi study, which was completed by 15 national experts, 5 from each of the 3 professions, and we asked them as well to identify drug combinations that they felt needed chemical analysis in order to improve patient quality of patient care. So we've done a total of 50 tests, 50 chemical analyses. 40 tests were looking at those from the database. So this has included 15 new combinations at minimum and maximum concentrations, plus 10 at minimum concentrations from the previous list that we looked at during the pilot study. We then also took 10 combinations from the Delphi study, or 10 tests from the Delphi study, because there are more weird and wonderful combination drugs that we use in palliative care that aren't used that frequently, so they didn't appear in the database, but clinicians felt that it would be useful for patient quality or quality of patient care if we had compatibility data for those. Now, we began testing in September 2013, and so far we haven't come across any incompatibilities. If we did, we would obviously report these immediately. Now, in terms of the chemical protocol, the analysis protocol, the syringes are being prepared as close to clinical practice as possible. We're using the T34 pump as the device that's going to stimulate the infusion. The samples are being taken at set time points, and we're using the Safety Intima Giving set, as again, to mirror local clinical practice. We hope to publish the results of these analyses beginning of 2015. And like I say, hopefully the majority of these combinations will be compatible. That book is one of the few books that are available that provide us with the information regarding the compatibility and stability of drug infusions. That's my name there at the bottom. Shamefully promoting my book. When the results of the ChemDel trial become available, obviously we will be publishing it in one of the recognised journals, but it will eventually also end up in that book. And that just remains for me to say thank you very much for coming. I know it's been the twilight zone, so thank you very much for the few that have turned up today. Any questions, please fire away. Okay. Just an anaesthetist.
Sorry, Nick Jeffries from Peterborough. Is this thing... No,
it is.
Okay. Yeah, the temptation to mix very small quantities of medications together when you've got the end of a syringe and you want to put something else into it. Are there any combinations there we need to be watching out for? Because there are some things that do throw off an obvious precipitate and need to be avoided. Paracoxib is one of those that tends to react. And
Yes.
Don't do that one. Is glycopyrrolate particularly reactive?
You have to try and keep it at an acidic pH. If it starts to become more alkaline, then it will esterify. So drugs such as dexamethasone, which are alkaline, phenobarbital is another alkaline drug, furosemide, you have to avoid combining those two together. Diamorphine is also similar. You have to try and keep that at an acidic pH, otherwise that starts to degrade as well.
And we've got one of the old 1 hour infusion pumps.
The MS-60.
The MS-60, which I use for infusing atracurium during laparotomies. Do I have to throw it away now?
December 2015, it has to go.
So I can get some bids in before then.
Yes.
Thank you very much.
Okay. Okay.
Historically, I was cycling only with air, water.
Yes.
My pharmacist just mentioned that I could put 10 ml of saline, I'll be all right.
No, cyclazine, you will get cyclazine hydrochloride precipitating. It's because of the chloride ions in the sodium chloride, and that causes cyclazine hydrochloride to precipitate. So no, cyclazine mustn't be diluted with saline. Again, just because you can't see the crystals doesn't mean to say that you haven't got little microcrystals that you can't actually see with the naked eye. What tends to happen is in the solution you'll start to get tiny little microcrystals forming, and then eventually they'll seed into bigger crystals which you'll be able to see. So to start with, you will get these little crystals forming, you won't see those, and obviously if you inject that into a patient's vein, then you're going to run into problems. Subcutaneously, it's not that big a problem, because obviously it's not going straight into a vein and you're not going to cause an embolus. But if you were to do something like that into somebody's vein, you might run into problems. Okay.
So another specific question.
Yeah.
Oxyclan.
Yeah.
You draw it out.
It looks like yellow brown. Is it degrading?
That is a good question, and I have no idea what the answer is, but I would suggest that if it's gone a different colour, then yes, it has.
Okay, because it happens very, very quickly. Thank you very much.
Okay.
What's the cost of the study that you're doing there here?
The study, we've had a £250,000 grant from CRUK and Marie Curie to do this study. We are in the process of looking at another 5-year study, which is looking at 48-hour infusions instead of 24, and that would be, it's looking at about £1 million grant over 5 years. But that's all I can say about that at the moment.
Hello, I'm not in palliative care, but is ketamine one of the drugs you're testing with your
It was identified in the Delphi study as one of the drugs that is used in the combination, so yes, that is one we're looking at.
Thank you.
Okay. Okay.
No more questions?
No more questions.
Okay, it just remains to say thank you very much to Andrew for coming and speaking. We did have a speaker cancel on us at last minute last week, so thank you, Andrew, for stepping in, and hopefully everybody's enjoyed it. I hope you've enjoyed the conference, and what am I going to do? Oh, sorry, just reminded there. Please, if you would, fill in the evaluation forms, because your opinion is important to us. So thank you very much. Enjoy the rest of the conference, and see you soon.